A very warm good afternoon to all. And on behalf of the Patient Blood Management Working Group of Asian Association of Transfusion Medicine, let me welcome one and all to this inaugural webinar. The theme of this webinar is Joining the Dots. So this theme was chosen because we all know that patient blood management is a multi-stakeholder process in which all the dots are very important, and it is very important to connect all the dots to give the best service to our patients. So for beginning the webinar, I respectfully call upon Dr. Navjyoti Chowdhury, President, AATM International, for the welcome address.
Thanks for your beginning. And, it's our pleasure to meet. It's like a family nowadays. We know each other. It's an international family having blood relation because everybody is from blood bank. May not have same blood group, but it's a blood relation. So this is one of those active forum nowadays, PBM. How it start? Actually, I am in the two WHO key meetings, and in WHO level, they very frequently talks about PBM. So this is a new topic, not started just probably a couple of months or years. So that it came to our mind that, okay, we should do something on PBM because we already had a working group. Then I got one of the mail from our coordinator, Dr. Amita. They said, can we start it? And that's how, okay, we started, and you will be one of the team members. So that's how we start. She is with us nowadays. So I will not take much time. Welcome everybody. And this is PBM is one of those 7 working groups in AATM. It's not the last, but we'll keep on improving, and we'll try to give the service to our members. A way forward, this is a little bit of complex because this is not our exact domain. Domain in the sense it's not only our blood bankers, it is the blood bankers as well as clinician. So, if in real sense, at least in some, developing countries, LMICs, we usually have a conflict with the clinician because they usually want to go for the whole blood transfusion. They want to go for over transfusion, single unit transfusion. So we do not agree with them. Having saying that, they are our, if you really see, they are our, customer. They are our end user. So we can, that's the dot we have to actually fill up. We should have a, and before going there to that, actually it is very interesting. AATM is working on 2 projects at this moment. This one project we have just submitted to the European Union. This is a Erasmus Plus project. Just on 17th, we have submitted with Barcelona University and Barcelona Blood Center. It is almost 800,000 euro project, but everybody pray so that we win this project. Here we really realize that there's a need for the communication. There's a gap in communication in case of AATM. That means in engineering, especially in India, in engineering and management, there's a special course for communication. But in medical, there's no communication skill courses, and we need more because we communicate with the patient, blood donor, we communicate with the patient, with the clinician. So that is one of the key area. So way forward for this group, what we would like to do, actually, we have thought about, there are clinicians, we have to take clinicians of the different groups. That's what we discussed in a small group with, with the chair and co-chairs. Probably we'll make small groups, and we'll try to develop some of this. We'll try to develop some of your, some of the documents, how patient management for specialty for hematology diseases, for maybe gynecologists. So we'll leave it to the decision of chairs and co-chairs, but ultimately we'll work on this so that something tangible, some documents comes up, and that is referable. We are doing something for the specialty. Again, we need some of the clinician. We have a plan, clinician, a different specialty, and all the members staying here, we will request you to recommend clinicians. Okay, this will be actually coordinated by the chair and co-chair. Recommend the clinician who can really contribute. And we are developing a module like, we have previously called them, we'll give them some status. They may not become an AATM member, but they can become something like an honorary member. That honorary membership we can provide with some benefits. But we leave it to the wisdom of this group, how they go ahead. But that's what we feel we can go forward. I think I have consumed my 5 minutes time, and over to you, and all the best. I know you are going to succeed, and more success in future. Thank you very much.
Thank you very much, sir. So next we move on to our distinguished chairpersons for this webinar.
Yes.
Our distinguished chairperson for this webinar, Dr. Sangeeta Pathak, Madam. She is Associate Director and Head Transfusion Medicine at the Max Super Specialty Hospital, New Delhi. And she has won so many awards and achievements. She got the Max Healthcare Chairman's Excellence Award in 2011, the recipient of J.J. Jolly Award in 2013. She has done more than 100 presentations in various national and international forums. She's a reviewer of many reputed journals. She's a certified NABH assessor. We welcome you, Madam.
Thank you. Thank you.
The next chairperson is Dr. Zainab Selim Said Alfana Al-Rami. Madam is from Oman, and she's the Director of Blood Bank Services in the Ministry of Health, Oman. And she's a member of many national committees for blood transfusion. And she has successfully established a National Blood Transfusion Committee and a Central NATCH testing project under the Ministry of Health in Oman. And she also has got many publications. So welcome you, Zainab, Madam. So over to you, chairpersons, for starting the webinar.
Thank you so much, Amita. And it's a pleasure to be here, both Zainab and me, to be here on this platform. And my proud pleasure and honor to introduce Dr. Poonam Malhotra Kapoor for her talk on anticoagulation in ECMO. So the introduction for Madam is that she is a professor with the Department of Cardiac Anesthesia and Critical Care. Her achievements and awards are: she is the Chief Editor, Journal of Cardiac Critical Care, Chairman for Academics and Secretary and Co-founder, the Simulation Society, past Chief Editor for Annals of Cardiac Anesthesia, Official Journal of IACTA, former coordinator. She is the President, Indian Association of Cardiothoracic and Vascular Anesthesiologists, President, Founder, Secretary, and Officer in charge of the Society of Cardiac Anesthesia, Delhi and NCR. From 2009 till date, she has numerous national and international publications to her credit, and her interest lies with ECMO, anticoagulation, TEE, monitoring, and simulation. So over to you, Dr. Poonam, ma'am, to give your talk on anticoagulation in ECMO. The next 20 minutes are with you. Thank you.
Thank you to all at AATM. I am really honored that I have been able to be attending the patient blood management programs across the country and abroad as well, because this is something that we, especially on ECMO and in cardiac critical care, were facing problems with. Our patients would die of stroke or intracranial hemorrhages, and we wouldn't have a clue how to monitor them till we started to use sonoclot and we started to do fibrinogen levels, and our results improved. So there's so much hidden so far, which we as clinicians don't know, but I'm sure this very elite panel of people that you've collected and AATM is something that I'm very, very honored to be a member and part of now. And I thank Dr. Ajay Gandhi as well as Dr. Klaus Gorlinger and the organizers today, all of you who have brought me here for this. Without much ado, we begin with the lecture on anticoagulation on ECMO.
Anticoagulation in ECMO, a very pertinent question today in 2021 when we are dealing post-COVID era, where cytokine thrombosis and cytokine storm have played havoc with many on the ventilator resorting to the need of ECMO. Greetings from AIMS, where I work and research on ECMO and anticoagulation. It's been a journey of 20 years with ECMO at AIMS. We've done well and we are still learning, and we have more to do before we can say that mortality on ECMO is not happening. Initiation of ECMO brings about hemodilution, dilutional coagulopathy, contact factor pathway activation, platelet activation with dysfunction and thrombocytopenia, inflammatory response with complement activation, and leading to generation of a thrombin storm. This thrombin storm can very nicely be taken care of if we are aware of what we are using as a blood product and what is the speed of the ECMO pump. The larger cannula size, the lower flows, the need to have more than 1 or 2 access cannulas, the need to do high RPM, high flow ECMO, change oxygenators if clots exist, and monitor bilirubin increase, urine color with hemolysis, renal function tests, increasing plasma-free hemoglobin and decreasing hemoglobin are all very, very pertinent to prevent the risk of hemolysis. But once you have beyond sepsis and beyond the presence of a failed ECMO failing due to the presence of intracranial hemorrhage, then it's important to rule out the gestational age of the patient. If it's a pediatric patient, was it less than 35 weeks? Birth trauma, thrombocytopenia, coagulopathy, sepsis, systemic heparinization, systemic hypertension, and seizures. If you see these are signs and symptoms of intracranial hemorrhage. So when we are doing the cannulation, let's say in this 13-year-old with ARDS who was in shock and put on VA ECMO on day 7, you receive that suddenly there's a need to increase the FiO2 from 0.8 to 1 and increase the RPMs of the sweep gas from 4 to 6.5 liters per minute. And the patient, otherwise stable with the saturation, CVP and all remaining the same from the baseline, is suddenly having seizures. When you receive some note like this, then you start looking at the circuit, start looking at the venous reservoir, the oxygenator. If you're on a roller pump or a centrifugal pump, MECA would be very, very different. We were on this pump, we shifted the entire circuit from the biomedicals to the MECA Quadrex oxygenator with the pump, centrifugal pump. Look out for the difference in color between the arterial and the venous lines. And is there any hemolysis? Is there any chattering? Look out for the bladder rupture. Look out for any signs of hemolysis in the patient's urine. Order an X-ray, see the position of the axis and the return cannulas, and these are the movements which you see, the chattering or the kicking lines of suggesting a drainage insufficiency in a patient. Check the circuit, check for clots, check the oxygenator, identify increase in pre-membrane and post-membrane pressures. Always, always keep your eyes on the oxygenator. The pre and the post-membrane pressures identifies as delta pressures should not exceed and be too much in the minus or too much in the plus. Always communicate, ask for help. The need to change the oxygenator and the circuit may be very pertinent. Always keep seeing your oxygenator, keep seeing how the quadrox is working. These are stacks of MPPA silicates, and these are very tightly packed within the oxygenator. See the run at the pre-membrane and the post-membrane sites, whether you're using an adult or a pediatric patient on a VB or a VA ECMO. Rule out hypoxia in this patient because seizures could be due to hypoxia. Ultraprotective ventilation is on with low tidal volume and low minute volume. See that the saturation, if you find, is less than 90 or 88%. Look out for reduced ECMO flows. Are they kicking or chattering of the lines? If they're fluctuating high inflow pressures, these pressures may become very negative and may tell you that there is volume depletion and the need to give fluids to this patient. And the patient may be too vasoconstricted by the use of high inotropes and may need vasodilatation. Add a vasodilator, inadequate venous drainage, rule out the cannula's malposition, rule out a cardiac tamponade, and rule out pneumothorax. Mechanical problems like cannulas, membrane thrombosis, changing of the circuit, check for cannula permeability, and see and do a recannulation if required, despite the fact that the patient is on a low-dose heparin infusion. If there is high oxygen consumption at PEEP, increase the hemoglobin, and you see there is a decrease in carbon dioxide, again, look for cannula replacements. And you know that fibrin deposition is happening, and you see that the membrane pressure of the oxygen pre and post membrane, if it's less than 300, then it's an oxygenator dysfunction, and consider immediately changing the oxygenator. Failure of the drive console or pump head to create forward circuit blood flow, clamp the circuit, call for help, switch off the AC line, engage the emergency drive, and rule out a differential hypoxia like a Harlequin syndrome and a reduced recirculation. And you may add an IBP if the patient's not improving, and you could add another venous line to this veno-arterial ECMO to enhance your drainage insufficiency by having more venous return and better ECMO flows. So decrease ECMO flows if they do happen and the patient's cardiac output is normal and the patient is not hypothermic, you may consider weaning this patient. So let's see what happens in a pump failure. This pump failure would be if allowed to persist, there's a knocking of the pump head onto the console, if allowed to persist, would always give rise to hemolysis. So clamp the post-oxygenator, alert, call for help, bring in the backup pump, switch off the AC power, and remove the pump head from the pump drive or the console. You can see that just with the push of the white button to release the adapter from the pump head, affix the pump head onto the hand crank, again adjusting the white button on the hand crank, and without further delay, once the pump head is on the hand crank, then as using the directions seen, well seated pump in the hand crank, you follow the arrow direction and start moving the hand crank at a rate of 1500 RPMs and slowly go up. Unclamp slowly and watch out for any airlock or air bubbles in the circuit. And once it is done, you could, the entire pump head is there. You could take your time now to affix a new pump. Now, if you have a major air embolism, then also a similar thing is happening, except this time the pump head which is seated there, and you've seen that there is air in the circuit. Now, what do? You draw out the air with the use of a 50 ml syringe. When something like this is happening, the clamp, alert, stop the entire AC power again and ask for help. Stop the pump completely. Once it is completely stopped, remove the pump head and debubble, tap it, debubble it, tap the circuit, walk the bubbles across onto the oxygenator, release the bubbles onto the oxygenator. There is an extra line onto the oxygenator, connect that to a 50 ml syringe, remove air from the venous port and take the note of the intake output charting. As we do, you take the note of the intake of the air bubbles, insert the pump head back into the pump drive and release the clamp very, very slowly, and slowly start and remember that heparin is not a direct thrombin inhibitor. It acts by activating antithrombin 3, so it's a prodrug. Antithrombin 3 converts in the common pathway where the extrinsic pathway using the tissue factor meets the intrinsic pathway. It drives the prothrombin into thrombin, and this thrombin, the 2A, converts the fibrinogen factor 1 into factor 1A, the activated form, which then forms a cross-link of the fibrin mesh and enhances the strength of your clot. Now, if something like this is not happening and heparin forms to the antithrombin therefore will also act through the extem, intem, and the fiftem. So heparin is responsible for the platelet aggregation. So whenever you put your patient on heparin and start ECMO, there is a thrombocytopenia. Why? Because the platelets aggregate, and initiation of ECMO brings about with heparin the form of thrombocytopenia. How do we monitor this heparin? ACT, APTT, anti-10A, but a point of care test like a rotum, sonoclot, or a rapid TEG or a classic TEG are best. You could see the chattering of the venous lines there, very, very fast chattering. This shows a drainage insufficiency on heparin, and you can think of all the negative venous pressures at the drainage access cannula site, inflow cannula site. Once this is happening, you see at the site of the surgical chamber where you have put it at the RA SVC junction, and you correct it by giving fluids and vasodilating this patient and ruling out a tension pneumothorax and a cardiac tamponade. Now, once you have seen this and the circuit is taken care of, let's see what we can do to the patient's blood, because the blood is undergoing major changes with heparin in it. Now, TEG, rotum, multiplate are all bedside viscoelastic measures which are integrity of coagulation, platelets, and fibrinolysis is very well seen. They tell us everything about the clot formation, the rate of clot formation, the rate of clot lysis, and the platelet function. But many studies on these substances are lacking. What have we been doing so far? We've been seeing the ACT, maintaining it between 160 to 250, and seeing the APTT target of 45 to 60 seconds or 60 to 80 seconds in some other centers. Heparin dosing protocol should be optimized to maintain a targeted heparin. We've been lucky to have Dr. Robert Bartlett, the father of ECMO, with us in New Delhi at the SWAC-ELSO 2018 annual conference, where his entire team from Michigan, Ann Arbor, with Mark Ogini as the president and Steve Conrad as the past president, met all our presidents, and we released our ECMO special journal of cardiac critical care. But it is research only that makes us go forward, and sonoclot with the functional hemostasis monitoring, assessing the platelet function, controlling the blood product usage, and differentiating the mechanical versus the hemostatic bleeders, with heparin resistant and HIT patients also being seen and screened for hyperfibrinolysis, has been a very, very important and pertinent viscoelastic measure, very easy to perform in the OT, in the ICU, at the bedside of the patient. How do we do it? This is a graphic representation. So on your y-axis, you are seeing the clot signal. So you can see how the clot is being formed, and that's the ACT that you get at 160 seconds. Once this is done, at 5 to 10 minutes, you see the peaking of the clot, and this is the strength of the clot. And then over the next 15 to 20 minutes or half an hour, this clot starts lysing. So DR15 is a very specific measure only on senoclot, and PF-SON is seen by this downside that you see of the entire breadth. How do we interpret it? Time until clot formation is the up on the y-axis. The rate of fibrin gel formation is the peaking, and clot retraction of the fibrin gel is the downside after the peak. So surgically acquired, you can see when you have a surgically acquired platelet dysfunction, you can see post-protamine, there would be no peaking. So pre-heparin, again, there is a peak. Post-protamine and giving platelets and cryoprecipitates, this peaking is less. If there is a clinical ooze, there is no peaking, and if there is no lysis and no downside and there is a steady plateau, it means your patient requires platelets. So pediatric cardiopulmonary bypass, you can see the clinical ooze again. It doesn't come down, it is up, 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 which means there's a platelet dysfunction, where the PF-SON, which is a parameter on sonoclot, would be more than 1.6 or less than 1.6. Now here you have a patient with a PF-SON of 0.9, no peaking, and you give a total correction patient, 3-year-old, normal hemostasis in the beginning. She couldn't come off bypass, was in low cardiac output. The platelet function was about 12, was about 2.3, which is on the high side, and everything though was going normal. When we gave protamine, our platelet function became 1.3. When you have low platelet function and some factor deficiency, then in a patient of TOF, and the patient is clinically oozing and there is excessive drainage, this is a patient now who requires platelets. So we gave 2 units of single donor platelets. This patient did well, but at the same time, this patient got so much of platelets that the clot rate, etc., became on the higher side. Now, when you are 35 clot rate, instead of the upper limit being 30, this is a hypercoagulable tendency. So this is a patient who does not need more blood now, doesn't need more platelets also, probably just a unit of FFP would suffice. Another patient coming for TOF did well in the pre-op period, has a platelet function of 13 and of 3.9, and 13 is the clot rate. This patient post-op, however, had a platelet function of just 0.9 with a clot rate of 15, and this 0.9 says, again, use single donor platelets, and in 24 hours, no re-ex required, give 2 units of platelets, and here you see this patient doing well. So as opposed to the normal situations where aim is to have a full coagulopathy control, in ECMO, there is no such control. You play with the coagulation system, and you play in such a way that there is no hypercoagulability, there is low fibrinogen being taken care of, and there is no hyperfibrinolysis. Beyond sonoclot, you have other factors like the ROTEM, the thromboelastometry, which is here to stay, the clotting time, the clot factor time, or clot firmness time, the A10 values, the A5 values, the maximum clot firmness, MCF values, and the lysis values are all seen very well on a ROTEM or TEG. So this is our ROTEM or TEG that we did early, as in 2016. And when we started to use ROTEM, we saw that the clot time on INTEM, EXTEM, and FIPTEM was high or low. If we saw the FIPTEM values low on this ROTEM machine, we knew using 4 channels of EXTEM, INTEM, FIPTEM, and HEPTEM, we could manipulate the pathway, the coagulation pathway. This is a machine with 4 channels. You can see the 4 channels here with the 4 cups, and these 4 cups with the 4 channels does wonders to the patient with all these 4, the EXTEM, the FIPTEM, they go hand in hand, and the INTEM and the HEPTEM, and that's a platelet signometry here, which is very nicely seen on this platelet aggregometry disc. So platelet parameters A6, they describe how well the platelets aggregate after selective activation. MS describes how quick the platelets aggregate after selective activation, and overall platelet aggregation is seen as area under the curve. We are seeing this as a very, very good marker as platelet function. The ROTEM parameters of EXTEM using cytokalasin D, cytokalasin D for APTEM and FIPTEM. For ECATEM, we use Icarin. For INTEM, we use heparinase. And for INTEM, we also use ellagic acid. So these are the different indicators. You can see fibrinogen deficiency in the low amplitude here. You can see this low amplitude. It is very, very little. It is less than 2. It's about 3. But the INTEM, the EXTEM, and the APTEM are normal. So when you have something like this happening, then you must know this is hypofibrinogenemia, give cryoprecipitate. But here, when you have lysis happening, the lowered amplitude and could be due to fibrinogen deficiency, but there's also a platelet deficiency because there is sudden hyperfibrinolysis here, sudden tapering, and this also continues in fibrinolysis. So, but it is taken care of when you neutralize all these three, that is in aptum. So this is a hyperfibrinolysis and the amplitude in aptum is back to normal. So we do a goal-directed therapy where you put in an EV1000 or a pulse contour analysis method or do an echo and see the cardiac output, the extravascular lung water, the global end diastolic volume index, and you see whether it's less than 10. Rotem as an accurate and rapid tool for analysis of coagulation pathways is here with us to stay. Platelet aggregometry can come up as a valuable tool to assess the platelet dysfunction, and reliable information on both hypofibrinogenemia as well as hyperfibrinolysis during ECMO with maximum amplitude as a sensitive predictor of diagnosing bleeding within 15 minutes of sampling is here to stay on the ADP-TEM, TRAPTEM, and ARA-TEM. You can put any two channels, see the maximum amplitude, and see that this MS at A6 is less with area under the curve, less or more. If it is normal, we'll do the test and we'll see. But we have moved into an era of algorithms. The clinical situation, is the patient bleeding still? Is the patient hypothermic? Is the patient agitated? Then make the sedation slightly better. Tranexamic acid should be given first, any antifibrinolytic agent, and then you see the protamine, heparin, protamine, rule out the residual effect of protamine, of heparin with protamine, C for the MCF, C for the cryoprecipitate use with 15 levels, C for blood platelet concentrate use with A5 and A10, XTEM and 15 levels again, and you give FFP as one of the last status in CT XTEM or CT HEPTEM when it is more than 280 seconds. So keep reassessing, keep seeing the algorithms. First, we used to, earlier days in 2014, we used to give FFP and then platelets and then cryo, and last we used to think of ECA. But today on adult CABG patients, we have this algorithm where on one side we do the platelet functions. You can see we're doing this platelet function wherein we are seeing the A6 less than 18 here. You're seeing the here you're seeing area under the curve less than 61, and the MS is less than 5. If you're seeing something like this on ADP-TEM, ARA-TEM as well as TRAP-TEM, then that's definitely it's a platelet dysfunction. This patient needs 2 to 3 units of single donor platelets or platelet concentrates, and simultaneously you see the 15 MCF, it is less than 7. You see the A10 15 if it is less than more than 7. You see the area under the curve, and you see the CT XTEM more than 80 upon 240 of the CT in TEM. When you see these values, then you know that platelet aggregometry is the faulty thing, and after giving cryo and platelets, you can give FFP, but first try cryo. My last 4 slide. ECMO for an arterial switch operation is 3 liters over 3 days, and the patient develops a cardiac tamponade with decreased cardiac output. Now, this is a patient where you can see the FFP is on the lower side. When the FFP is on the lower side, then here you can see with the FFP on the lower side, you can see that this patient needs fibrinogen. Here the FFP is less than 2 and the XTEM is less than 28. So when something like this is happening, what and how do you calculate the dose of your cryoprecipitate? Well, the best thing is 10 units of cryoprecipitate is equal to 2 grams of fibrinogen concentrate after taking into account the amount of millimeters you want into the body weight in kg divided by 160. So that's the correction factor also we use. And this mnemonic is given by the company, Werfen, which deals with the Rotem and the Verify Now. And let's say if the 15 A10 is less than 2, in this case, we want to make it 10. So we 10 or 8 maybe. So if we want to increase it by 6, so we need 37.5 milligram per kg body weight of the fibrinogen dose, which would be about 1.9 ml, and for that we need about a cryoprecipitate of 3 units, 3, which is about 15 units. So we gave to this patient 15 units of cryoprecipitate, and the 15 values came to be near normal, around 7 to 8 they became, and the platelet function with area under the curve came out to be very, very good too. So this is another case, post CABG, unable to wean off CPP, went into cardiogenic shock. We put the patient, and he was very in low output and very oozy. So we put the patient on ECMO and we did a Rotem, and we found that there is hyperfibrinolysis here with a flat line on 15. Here you can see that the 15 is a flat line, and the platelet function was decreased, area under the curve would decrease here as well. This is a case of hyperfibrinolysis. After giving tranexamic acid 25 milligram as single bolus dose, you can see the results came to normal. Another case of post-Bentral patient continued to drain for 7 hours, no effect of any blood product usage. Rotem findings showed interim CT to be high as well as decreased amplitude on interim, and the heptim CT is close to normal and better than that of interim. But you have a flat line here on the platelet functions. You can see here the platelet function shows flat lines. So when you have something like this is a case of heparin influence. Prolonged CT in interim more than 240 seconds, that means decreased platelet functions. Give to this patient protamine and interim CT becomes normal. Give some platelets to this patient and your platelet function becomes normal. Post-dengue, you are very fearful of hemorrhagic fever. CABG and bleeding post-CABG remained high in this patient, so we gave VA ECMO. And once we put in the VA ECMO, we found decreased clot firmness here on fiptum, as well as though the fiptum looked normal, but in extem there was decreased MCF and low area under the curve in platelet function. This is very, very common in all patients who are on heparin infusion, and that's why it's important to decrease the heparin. So give to this patient platelet concentrates 2 to 3 units pooled, and platelet functions of extem, interim, and the ADP and the AATM become very good. So despite ECMO experience, evidence-based guidelines for anticoagulation management are still lacking. Antithrombin 3 remains the cornerstone of anticoagulation during ECMO while using heparin and is the classical test with APTT and ACT. But beyond this, point of care testing lead to better anticoagulation management, and there is an urgent need for well-documented research on point of care tests during ECMO and their adoption and interpretation with the right blood component and the right drug usage so that we can have a successful ECMO run. I invite you all to join us for, this was the SWAT also that we did in 2018. We do fellowships in ECMO, this online ECMO, with some hands-on we do at some or the other hospital. We also do online cardiodiabetes, cardiac nutrition, patient blood management, cardiac nutrition with a lot of book writing. This is our passion and this is our aim, to read, write, research, and do well for our patients. Thank you all.
Thank you, Dr. Poonam, for such an interesting, illustrious, and an observant talk. Thank you so much for that. And we would be taking the questions after the second talk. So I hand over the mic now to Dr. Zainab to introduce the next speaker and take on. Dr. Zainab, please.
Thank you very much. So our next speaker is Dr. Ajay Gandhi. He has a lot of experience in patient blood management, and his present attachment is he is an associate director clinical affairs from Warfan Academy, India. He has a lot of publications, and his interest in hematology, patient blood management, a clinical director, bleeding management. And as I can see, he has a lot of achievements and awards related to the patient blood management. He's the primary author for the first publications on patient blood management recommendations from India. And he's the founder for the certificate course in patient blood management, India. And it is my pleasure to welcome Dr. Ajay Gandhi to give us some information about patient blood management experience in India, journey so far, and the way forward. So welcome, Dr. Ajay.
So namaskar, everyone. Thanks, Dr. Jainab, for the kind introduction. I would like to thank Asian Association of Transfusion Medicine, the leadership, especially Dr. Sadhna ma'am for bringing this together and giving me an opportunity to share my perspective on patient blood management within India and around. So I hope all of you can see my slides. Okay. So I'll skip the disclosures because they have been spoken of already. And I cannot begin my presentation until I acknowledge my gratitude towards the people who have made me, worthy enough to participate in such an august gathering. Dr. Axel Hoffman, Dr. Klaus Gollinger, Professor Donna Safan, Poonam Malhotra Kapoor ma'am, Dr. Thizot, Dr. Navjoti Chaudhary, Sadhna ma'am, Dr. Gajendra Gupta, one of my mentors, and of course, Asian Association of Transfusion Medicine. This is the agenda which has been spoken of. I'll be talking about the state of affairs within India and beyond of patient blood management, some perceptions and practices, gaps and barriers that we need to take into account, the journey that has been covered so far, and the way forward. So what is the problem statement, or say, let's not begin on a negative note, let's begin to understand what is the state of affairs within India of the patient blood management. So if you look at Indian perspective, usually there is a very non-uniform or a very diverse kind of a healthcare infrastructure which is in practice. There is still no universal standard practices. I think most of us who are part of this webinar today are aware of this fact in our respective countries and regions, that this is a fact. Well, good news is that the journey for patient blood management implementation of practices and principles has begun, but believe me, there is a long distance to go when we talk now. Of course, we've been talking about guidelines and recommendations, which we'll be seeing in the later part of the day today, and then we need to understand that still we are following the traditional blood practices, transfusion practices. If you look at the South Asia and the Middle East perspective of patient blood management, this is a study which was not very far off, but around 5-6 years back, which was done to assess the level of maternal mortality, which remains the #1 killer in the region that we are part of today. So if you look at the figures in the countries where most of the participants are belonging to in this webinar today, with the Saudi Arabia, Sri Lanka, India, Pakistan, Nepal, Afghanistan. So you see, these are very sorry state of figures when we look at the maternal mortality as such in general for these countries and regions. Now, often a question arises as to what begets what. Is it anemia that gets bleeding, or it's bleeding that gets anemia? Essentially, I would say it's a triad which is a vicious cycle. The anemia or the iron deficiency leads to, I would say, transfusion, and that could be rational or irrational, which further aggravates or sort of complicates the blood loss and the bleeding that is happening in a patient, which again in turn eventually leads to anemia once again. So it's a vicious cycle. We don't need to get into the prerogative of whether it is happening, what is happening first. Eventually, the bottom line is there is an unmet need to manage and preserve patients' own blood. Reason being, the transfusion of allogenic blood components still the default therapy in most of these situations. Now, what are the perceptions, protocols, and policies and practices that we have been talking about? When we talk about stakeholders, I'm sure I missed the introduction part. I'm sure we all are looking at stakeholder. Who should be the key person involved into patient blood management? Is it the surgeon? Is it the anesthetist? Is it the transfusion specialist? Is it a hematologist, an intensivist? Whether we're talking about the administration of a hospital, or we're talking about the policymakers from the health regulators in general. So believe me, it is not a single party game. It is not a single specialty fraternity subject when we talk about. We talk here about multiple stakeholders working as a multidisciplinary team. Few perceptions and practices that I would like to highlight here, not throw light upon, but highlight here is who should be taking the accountability and a responsibility of a patient who's either likely to bleed or is bleeding eventually at the given point of time. Still, it is the person who's the consultant in charge, holds the specialty, that specialty holds the accountability for that particular patient. If it's an orthopedic patient, it's an orthopedician who's responsible for, say, the bleeding management. If it's a gynecologist, it's an obstetrician or a gynecologist who's responsible. If it's a cardiac surgery, it's a cardiovascular surgeon who's responsible primarily for the blood management of that particular patient. Now, most of us, we resort to either early blood transfusions or ratio-based blood transfusion practices. We currently speak, we've been talking for more than 2 decades now, but still, believe me, more than 70% centers within South Asia are still conforming to these facts, which is early blood transfusion and ratio-based practices. Again, there has to be an awareness around requirement versus availability of either the pharmaceutical agents or the blood components which are needed to manage such bleeding patients who are either bleeding or are likely to bleed. Mostly the practices that we currently follow are driven either by tempting to correct the numbers as in the reports that we get from the pre-anesthetic checkup of a patient, maybe it's PT or INR or BT or whatever, or precautionary transfusion. This patient has low platelets. It's going for a surgery. Let's transfuse either PEC red cells or let's transfuse platelets to such a patient because we know this patient might bleed. Then this all is based, the fundamental problem is on poor predictors of bleeding. The kind of diagnostic methodology that we use in our day-to-day practice, still they are evidence to be poor predictors of bleeding, whatever we are using today. Of course, old habits die hard. Some universal barriers which I would like to throw light upon is there is in general a lack of awareness amongst patients as well as patients' organizations. It's not just the doctors. Even the patient need to have an awareness on what's going around with their blood, with their management, if they're likely to bleed or they're already bleeding. There is lack of awareness in the health authorities, public health experts, economists. Nobody's talking about the kind of health economic adverse effects these transfusion can have if they are not given based on certain goal-directed therapy or based on certain rational protocols. In general, there is a lot of talk on 3 words PBM, but there is still a long way when it comes to going to the implementation part of the PBM journey so far. So it's just that we all are contributing whatever we can in our best possible way to take forward the campaign of PBM awareness and implementation in our regions. Well, nobody knows when the fire actually started burning, but this is it's more than 3 decades a paper, which was published somewhere in 1990, where it was very specifically concluded that amount of transfused products was inversely proportional to the physician knowledge of transfusion medicine. Believe me, this is not just 32-year-old. This is just 32 seconds old. This still stays. If a physician, a handling physician or a surgeon is aware of the protocols and principles, believe me, the transfusion products are going to go low. The transfusions are going to go low. We started our journey way back in 2019. Of course, the group from Portugal, inspired us to do work like this, where we had a scientific advisory committee meeting on patient blood management, where 16 experts from multiple specialties came together, be it transfusion medicine, be it surgery, be it cardiovascular surgery, liver transplant, anesthesia, hematology, be it laboratory or a clinical hematology. Everybody was present. In fact, Dr. Gajen Gupta and Dr. Poonam Malhotra Kapoor were a part of this particular advisory committee that was formed way back around 2 years back, with the aim of forming consensus statements and recommendations on practices and principles of patient blood management. And they envisioned to have a wide reach campaign on patient blood management awareness. That was the day the group started working towards having more and more outreach on the subject matter as such. There was a lot of brainstorming. There was a very widely circulated survey that was done on understanding the practices and exploring the rationales. Thereby, some propositions were made, and finally the consensus was drafted, which were further refined before conclusions were published in its current form, which is the patient blood management in India. This is probably the first set of guidelines or recommendations from Indian medical practice in as many years as it has existed rationally before the rest of us. Some of the key miss outs that were picked up in this entire study, which lasted for 3 years, was there is still an incomplete medical education curriculum. I'm not saying that our curriculum is not good. It's comprehensive, it's wonderful, but still there is no dedicated subject matter on patient blood management as such. It is still in bits and spurts. There has to be more focus on a specialized learning, which is still missing. The healthcare infrastructure is still skewed. People tend to have the best practices in the metros or tertiary or the referral centers. And the biggest bottleneck, believe me, is one, the logistical flow of patient from where he or she is bleeding to where he or she can be managed. One. Two, the availability of skill set. I'm not saying there is a gray area of competence, but there is a skill set required to bring in and practice the principles of patient blood management. This remains a major bottleneck. One, which is not mentioned in the slides that I'm sharing currently, is another one is we have no defined trigger points. When do we call it? Yes, this is how this patient needs to be handled. This is where it needs to be referred to. This is where we need to start thinking of transfusion. Those trigger points were absent until we got these recommendations on the public forum to be able to share with larger fraternity of doctors around us. Bleeding history assessment, believe me, is one of the most effective means of predicting bleeding in a patient. And this is highly, highly underutilized. Still, we rely on bleeding time and PT-INRs and APTT in our laboratory screen test or pre-anesthetic workup. Most important, where I feel presence of policymakers is important, is we are still talking about vertical system-based management. We're not talking about horizontals. We're not talking about crosstalk between departments. We're not talking about a multidisciplinary approach. Some of the identified barriers to best practices within this group that brought forward was there is a lack of awareness amongst policymakers, healthcare professionals, hospital administrators, analysts and advisors. Now, this particular area, analysts and advisors are prominently or conspicuously missing from the main picture. If we start analyzing, if all of us go back to our respective institutions, analyze the data of previous 1 year or 6 months or 2 years, whatever is available, and try to retrospectively follow up patients who have received transfusion, I'm sure we'll have some shocking revelations made in that particular analysis. Then there is a lack of awareness around principles and practice of PBM, which is gaining popularity now, gaining visibility now. Infrastructure requirement for managing bleeding is very, very important. In fact, in our recommendations, we even tried to stratify the availability of infrastructure based on levels of healthcare. It's not that a primary healthcare center will have all the facilities, all the equipment, and all the specialists to manage bleeding. No, we try to stratify it in such a way that this is what is required minimum at this particular level of healthcare. And this is the trigger point which needs to make sure that you are going to the next level of healthcare if you're not able to meet these certain specified criteria. Then we talked about, which is still missing phenomenally, is we all have a lot of research papers. We all have a lot of published articles around us. But believe me, many of us, most of us still are not adopting evidence-based algorithms on bleeding management. We are still either giving it a hit or try, or we are just blindly copy pasting whatever is happening or whatever is proven to be correct. This is not bad, but yes, validation of what is existing it needs to be done at some point of time. Way forward, well, I'm sure most of you are aware the last 2 years have been very, very phenomenal in terms of creating highest amount of awareness on patient blood management. We have done 2 successful editions of patient blood management. In fact, we have so far covered more than 500 people from across more than 15 countries from 3 continents who have benefited from this entire exercise of awareness across the ecosystem. And I'm sure this is just the beginning. We have many more to come going forward. The idea is to have more awareness, more direction of movements from awareness to implementation. How this will happen? First, we involve all stakeholders, everybody, the clinicians, the nurses, the allied health professionals who deal with blood. We educate them, we enable them, we empower them. How we educate? We're doing it today. How we enable them? We give the right kind of infrastructure. How we empower them? Yes, this is very important. They cannot just, I'm not naming few people, but I get a lot of queries on people have a lot of ideas, a lot of innovations, which they feel they have in their hand, but they are not allowed to express it. Empower them, let them come out with ideas. Maybe what so-called seniors or I would say seasoned people cannot do, maybe the young lads or new people can contribute more innovatively or improvisatively to the entire aspect of implementation. Yes, we are thankful to many medical associations and forums which have been supporting us, NATA, SABAM, of course, Asian Association of Transfusion Medicine, WHO, and of course, PBM working group from Dr. Axel Hoffman. How do we implement that change? This is important. First, we ditch off, we just finish what we usually call as blood transfusion committee in a hospital. We start working or renaming it, restructuring it as PBM task force. And another important thing, PBM is a subject matter in health education, should be incorporated in our daily MBBS curriculum itself. We track and audit the BT recipient. This is what I was talking about, going back and studying what is happening. We need analysts to take care of what's happening. And we need to have better or effective bleeding management tools. Last 2 slides, learning and sharing is probably the most important. Now, this is one institute. Can the admin please? Yeah, there's a lot of, okay. So this is one institute I sort of boast around. I'm sure some of these people are still present in amongst us. Jubilee Mission Medical College in Thrissur has been one example I always quote because they have gone to the next level of not only learning and adopting, but so much so that now they have become a success story and they are able to share their journey with the rest of them. We've been doing it at many places. We've done it with Sri Lanka College of Hematologists. We've done it with Cardiac Society of Nepal and even Sri Lanka College of Transfusion Physicians. We continue to do such activities across the forum with these associations. Again, the idea is learning and sharing. Nobody is a learned person. Nobody is learning. Everybody should learn whatever new he or she comes across, and everybody should share whatever he or she has excelled in or experienced it. There are a lot of success stories in making. I'm sure Poonam Madam has already expressed in terms of All India Institute of Medical Sciences, New Delhi. Then ILBS, Jubilee Mission, I've already spoken about. Women College in Women Hospital in Sri Lanka, King Saud Medical City, Saudi Arabia, and Shahid Gangalal National Heart Center, Nepal. Now, these are some of the stories in making, and believe me, going forward, we will have people from these representatives from these institutes and regions who will be sharing their success story, and they will be inspiring us to continue to move on with the momentum. Finally, my last slide is to talk on the paradigm change. We have been talking for ages about transfusion medicine, transfusion medicine, transfusion medicine. It is time we start calling it more holistic as a patient blood management science, with taking care of all the 3 pillars. It's not just about devices and technologies. Many people considered, oh, PBM means a viscoelastic testing device. No, no, no. It is a combination of amalgamation of all three pillars, where not only you optimize the red cell mass of a patient before he or she goes to a procedure, you make sure that you're minimizing the blood loss as well as the bleeding, if at all it happens. Finally, you harness and optimize the physiological reserve of anemia, increase the tolerance of the patient to anemia when the patient is shifted to the ICU and beyond. And that is the reason why WHO has come out with an urgent need to implement patient blood management. But having said that, this is a big ambiguous statement. I am particularly not very encouraged and excited about the way it has been taken up. The perception is different. This does not mean we all have to start forming guidelines in our respective countries, hospitals or regions or states. No, we have to start working on developing the mandate that we need to keep it evolving in a more structured process. That's it from my side. This is the last slide. I'll stop sharing my slides here.
Thank you, Dr. Ajay Gandhi, for the excellent presentation and the wonderful work you have done in establishing and implementing patient blood management in India. And yes, I agree with you that it's really very challenging. And also from our experience in Oman, we found that the last two years is an opportunity to develop patient blood management. Because during COVID-19, most of the blood banks in the region had a severe shortage of blood. And one of the ways to improve the blood components availability is to encourage practicing patient blood management. And it was really an opportunity to develop it in many countries. I can see that there is no questions on the session. Is there any questions from the audience, please?
I have one comment to make for Dr. Gandhi. Dr. Ajay Gandhi, I just loved your second last slide of transforming a transfusion medicine to PBM. I just loved it because we have been struggling for calling it from a blood bank to a blood center to a transfusion medicine. And today you gave us a different terminology for the transfusion medicine as PBM. That's an eye-opener for all of us. We were looking at PBM, but in terms of transfusion medicine, converting to PBM, that was a very interesting slide. So thank you so much for that. Thanks.
Thank you, ma'am. My pleasure. Just my thought, maybe the health policy makers adopt it somehow. We are nobody to call it ourselves. We need policy makers.
That's what I know. Dr. Zainab, we can introduce Dr. Rasika and hand over the mic to the moderator.
Yes. So we will
Okay.
now move on to the panel discussion. We will move to the panel discussion. I welcome Dr. Rasika Madam.
Hello.
Rasika Madam,
Hello, yes. So,
she's Associate Director and
hello.
DLK Max Super Specialty Hospital, New Delhi. She's an NABL assessor. She has got more than 30 publications. And I welcome Dr. Rasika Madam to continue with the panel discussion as moderator.
Jamita, and it is an honor to be hosting the panel discussion on a very important topic, the patient blood management. Evidence demonstrates that PBM significantly improves outcomes and safety while reducing costs by macroeconomic magnitudes, and despite its huge potential to improve healthcare system, PBM implementation still remains a challenge. The aim of the panel discussion today is to thrash out the various challenges that may come in the course of PBM implementation in this part of the world. On the panel, we have a diverse group of experts in the PBM implementers across countries reflecting different healthcare contexts, with the aim of gaining experience from them to develop guidelines for initiating and orchestrating PBM implementation in our subcontinent and making patient blood management a new norm, or maybe we can say a new normal. So on the panel, we have Dr. Amit Shrestha. Dr. Amit Shrestha is working as the unit chief and consultant hematologist, Nepal Cancer and Research Center. And he has received various awards for his work in thalassemia and hemophilia. He has many publications to his credit and has keen interest in standards of blood transfusion services in Nepal, hemovigilance and guidelines on waste management. Next on the panel is Dr. Poonam Malhotra. She's already been introduced, so I'll skip her introduction. Next, joining us on the panel is Dr. Nina Kureshi. She is a Dow graduate who postgraduated and did a fellowship in hematology from Liaquat National Hospital, Karachi. She's held very important positions in Riyadh and Karachi in different positions, and currently is working as a head and consultant hematologist at the Kidney Center PGTI, and is also the active member of Atom Transfusion Medicine and is leading the Pakistan chapter as vice president chairperson, and has various publications to her credit, and is working as a consultative, gives consultative clinics in hematologic disorders and has interest in plasma dyscrasias. Next on the panel is Dr. Ibrahim Aikar. Dr. Ibrahim is the Associate Professor in Pediatric Hematology and Oncology in Afyon Karhisar Health Sciences University, Faculty Medicine. I hope I've got this spelling right. I must admit that I did Google the name to get the pronunciation correct. And it was very interesting. It's a very beautiful city where he works, and Afyon stands for opium, and Karhisar is a black castle that sits on the top of a hill in this beautiful city. And I think during the course of PBM implementation, one day Dr. Ibrahim will invite us over and we may get to see this beautiful city. And he holds various positions in this institute at various levels. He has received many awards and for his work in transfusion medicine, hematology, and hematopoietic stem cell transplantation, many publications to his credit, and has keen interest in hemovigilance and PBM. Then we have Dr. Asavri Bapat, the Global Regenerative Medicine Consultant, on the panel next. And she works as a VP Quality and Regulatory Affairs, Regenerative Medicine, Info Health, FZ, along with various other positions that she holds. And she's the International Ambassador for AABB, and also is the Atom country head for Dubai, UAE. She again has been a speaker, moderator, and panelist for international conferences and meetings, and well published in many international publications. And last but not the least is Dr. Ajay Gandhi, who already has been introduced, and he has a lot of experience behind him for inpatient blood management, and is a pioneer in our country in implementation of patient blood management. So, not wasting much time, I will actually like to put the first question to Dr. Amit Shrestha. Dr. Amit, what is the origin of PBM? How, when, and who started it? And what is the scenario of PBM across the globe? Dr. Amit, over to you.
Well, the term PBM was first introduced by Professor James Isbester, a hematologist from Australia. And in 2005, he had published an article in a journal, update in blood consumption and transfusion alternatives. And in this article, he had used the term patient blood management, and noting that the focus should be changed from the blood products, to the patient safety, patient care. And initially, it was developed to improve outcomes in surgical patients. But later in Western Australia, for the first time, it was being used in a large scale, and which was being funded by the government. And the program ran from 2008 to 2012, and that the program was associated with significantly improved outcomes, with decrease, which showed the studies showed that there were decreased use of blood products, and the patient morbidity and mortality rates were decreased, and also the saving of millions of dollars was being noted. And as a result, in 2010, World Health Assembly had endorsed the term patient blood management And since then, many different countries have been started implementing it. But since this is a paradigm shift from blood transfusion to the transfusion to patient safety, still there's a lot of challenges in implementing in different countries. And the main reason behind the challenge is the lack of awareness in people and the healthcare professionals. So recently, WHO has been emphasizing to implement it to the earliest, but because of the lack of awareness, there are a lot of challenges being faced by different countries. And talking about my country, Nepal, we still are in it's a very new topic in Nepal. And I think it's recently, only in December 6th, we had a PVM program for the first time, organized by the Cardiothoracic Society. And we had Dr. Gandhi as one of the key speaker. But since we don't have any definitive national guidelines or anything, so it's a challenge in Nepal itself. Overall, what I would like to say is that because of this shifting paradigm from blood transfusion to the patient care, it's still a challenge in implementing it. And the main reason is the lack of awareness among the people, and which should be overcome. Thank you.
Thank you so much, Dr. Amit. I think, it was very important for us to know. We all call it recent, but it's almost 2 decades now that, this thought has been there, and, all of us have been munching it over. But now it's time, it's time to implement it, just not think over it and, just try to, we just, testing waters. It's now time that we actually dive in and get things moving, because 2 decades we've got ample time. We have people in different parts of the country, the globe, who've actually implemented partially, somewhere people have done it. So I think it is very important to know, because all of us should know that, it has a lot of water has flown down since then, and we should be actually implementing it. Thank you, Dr. Amit. Now, my next question is to Dr. Ibrahim. Dr. Ibrahim, who do you think should drive the PVM campaign? Is it a specialty? Is it a group of doctors? Is it a government agency, healthcare regulator, and why? And again, there's a very important question, being transfusion medicine people. Will implementation of PVM increase in the wastage of blood and blood products? Because, that is a big concern that all of us do have. So I'll request you to address these 2 very important questions. Dr. Ibrahim.
Thank you very much, Rizka. But there is nothing left from after Gandhi's speaking, I think, to me. I will briefly answer your questions, but thanks Gandhi, it was very good, his presentation. There was a lot of answers for your questions there. I will say shortly like this, all of them to your question, because the success of the patient blood management campaign depends on the belief and ownership of all these stakeholders you mentioned in your question, and also depends on their effective, active, and successful fulfillment of their duties and responsibilities, working together in harmony. For the establishment of patient blood management, government agency or health regulator is key stakeholder of the patient blood management campaign. Namely, government agency or health regulator can significantly influence the course of action. They develop or have a high level of power and interest in the course of action. But patient representatives, physicians, nurses, perfusionists, clinical pharmacists, hospital administrators, transfusion medicine departments, hospital blood bank heads, blood service, clinical department heads are primary PBM stakeholders. It means they are those who are ultimately involved in or affected by the course of PPM action. Government agencies media doctors, patient organizations, and medical journalists are secondary PBM stakeholders. It means they are individuals or groups that have a role in the decision making in the course of PBM action without being directly impacted or being impacted to a lesser degree. The PBM establishment will be successful with the high level of power and interest of the government agency or health regulator in the course and with the compatible work of primary PBM stakeholders and secondary PBM stakeholders. Under this high level of power and interest of the government agency or health regulator. A Turkish proverb says, it is harder to break people's prejudice than to break the wall. Patience, endurance, persistence, awareness raising, and support of the hospital management about PBM, visits and information meetings with small core groups to clinical department heads and their staff are the key factors on successful PBM drive and for breaking people's prejudice about PBM. Also not meeting the health expenses of patients who had anemia before elective surgeries and were operated without correction of anemia will help very much on the implementation of PBM. About your second question, in the literature, there are a lot of studies showing that with the successful implementation of patient blood management programs, very high levels of blood and blood products wastage are reduced in contrast to the increase in wastage. These are very good examples about fear of increase in wastage of blood or blood products if PBM is implemented is ill-funded is not true. A PBM program, however, can result in hospital-wide cost savings, particularly due to the reduced cost of blood products, blood wastage, laboratory analysis, and reduced expenses associated with adverse events. Thereby, successful implementation of PBM may result in huge cost savings. With the proactive and tightly controlled blood center stock follow-up studies to be carried out simultaneously with the patient blood management studies in hospitals, the Westies that are worried about the use of blood and blood products that will decrease with the success of the patient blood management studies can be prevented. With this kind of work in our hospital, we managed to reduce the waste of blood and blood products below 1%, even though we switched to the patient blood management program. That's all I have to say. Thank you very much again, Jessica. It is my honor to be here.
Thank you so much, Dr. Ibrahim. I think you've covered it actually very well. There is no one single driver. We cannot have one driver. And it is, whenever we talk of patient blood management, it just puts, when down south, when you have these people who are doing canoeing, you see all of them have their oars lifting up at the same time and going in at the same time for the boat to, for the canoe to move forward. So it is something like, if one of us falls out of sync, we'll probably lose the direction. So very well said that, there's not one driver, but all of us have to drive this program in all the specialities, wherever it is, whether it is the regulators, whether it is the clinicians, whether it is the transfusion medicine experts. And yes, thank you. I mean, that thought is that, it will not increase wastage. It will actually increase the judicious use of the blood and blood products, because there are many patients who will still be requiring it, and we will put it to more effective use. Thank you, Dr. Ibrahim. My next question is to Dr. Hina. Dr. Hina, what are the biggest challenges in implementing PBM in a country or a region? And what are the strongest negatives, as we say, or don'ts for implementing a PBM? Dr. Hina, over to you.
So thank you very much, and big thank for organizing this event. This is Dr. Nina Kureshi from Pakistan, and my question that you have just asked is already actually answered very beautifully by Dr. Ajay Gandhi. The whole presentation was on this question, based on this question. So there, he has described the barriers very well and all the challenges that he has discussed. In fact, whatever I prepared for my question, he has already answered that. So I will reiterate that. As for the don'ts are concerned, of course, the knowledge, the stake, and Dr. Navjyoti has in the start, he said, okay, this is a relatively new topic for the blood bankers, and it's not that much related to the blood bankers as much as it is related to the clinicians, to the physicians, to other stakeholders who are involved in blood transfusion of patients. So when we discuss the 3 pillars, and we say that how to appropriately use it, does the clinician even knows that if there is iron deficiency, it has to be treated for an elective surgical procedure and not that it's an easy way, taking an easy pathway to just transfuse the blood to the patient and go ahead with the surgical procedures. So again, I will reiterate Dr. Ajay Gandhi's words that the amount of transfusion inversely proportional to the physician's knowledge. So this is where we have to work hard. And again, starting when we say that we are talking to we are concerned with the physicians in PBM, in Pakistan, there is just 1.1 doctor for 1,000 patients, right? The ratio is too low. And about 50% of these patients do get transfusion at some point in time. So hardly there are doctors who are taking this issue. And so at the curriculum level, this should be imparted at the curriculum level. And from the curriculum, the 2 most important things that I've always been advocating at curriculum level is infection control and this transfusion. How a patient should be transfused, what is the appropriate use of transfusion, how it's not just from one vein to another. That chapter is over now. From one vein to another is just a part of it. The actual thing starts when the patient enters the clinician's office. So this is these are the challenges that we have to address to, and of course, to increase the knowledge, to increase the resources, the infrastructure, as Dr. Ajay said. So all these things and all the stakeholders have to be considered in this PBM. Thank you.
Thank you so much, Dr. Hina. And I think you've actually, summarized it very well. It has to start from the education level of the doctors. You're right, as you rightly said, it has to be a part of the undergraduate program, and then we can implement it. And a very important thing is also the patient. When we talk of all the key stakeholders, the patients are also an important key stakeholders, because most of the healthcare things are driven by patients. Where patients demand and then we deliver. So I think that is very well covered. And my next question is to Dr. Asavri. Dr. Asavri, what are some of the innovative strategies adopted in the developed world to ensure PBM implementation? And what could be some of the innovative strategies that we can adopt to ensure effective PBM implementation in this part of the world?
Thank you so much, Rasika. I hope you can hear me well. First and foremost, thank you so much to all the organizers. Such a wonderful event. Thank you, Dr. Sadhna, Sangeeta, Dr. Rasika, everyone. And thank you to AATM for organizing this event. So having said that, what I would like to say is my initial training was in India, then I moved to Australia, in US, and now in Dubai, as well as based in, US. Most of my background, although I came from a blood banking background, is these days mostly in cell therapies, but we do facility management for many of the global facilities worldwide. And Dr. Gandhi touched on many of the topics, and we heard that, and Dr. Poonam ma'am also, she presented very well on some of the aspects. The major differences are there's a significant variation in how we perceive some of the education and learning in India and some of the education and learning that we do abroad. We are definitely trying to bridge the gap through webinars such as these and having a discussion. As you know, there's a lot of difference between how we take chemotherapy or patient care for our patients. If it is a Western or a developed world, we manage perioperatively the patient in a different way than what we do it in India. There are a lot of factors which are involved in that. The other thing that we have been having a discussion is also the clinical responsibilities. I think, as Dr. Ibrahim mentioned before me, that there are a lot of other stakeholders. And whether we go to a medical school, give trainings to our doctors, our nurses, training is a very important part of all of this as a PBM. When we're talking to clinicians, what we have also done, some of the strategies now that we have started to implement is we are doing quality by design. So we actually design a specific program based for your facility. Dr. Gandhi had mentioned in this thing that we sometimes just cut and paste or copy paste some of the programs, and they don't really work because you have to design your own change. And it has to start in a smaller way of educating and learning. One is giving webinars or educating your staff, but then the second point is how did they perceive it? So we have broken it into simple pieces. One is the knowledge, where we go through education, whether it's learning, teaching, all of that. Then we look at the action. How did it transfer into the communications that they started? Did they start ordering less of blood? They started utilizing, the correct parameters that we are doing. And then at the end of the day, we look at the behavior. So maybe a quarterly, sometimes even monthly, we look at how many units have been saved, how many units were ordered. The biggest hindrance in all of this is what we realized is the main strategy is how do your clinicians or doctors perceive the risk? Sometimes they think that I'm going to lose a patient. I may not have enough blood to take care of my patient. So you have to reiterate saying, we always have an emergency, allotment, which you can always go back to and take it down. Plus the clinical knowledge. Dr. Poonam ma'am also spoke about ECMO, and especially during the COVID perception, we all had to learn about different strategies of how we can maximize, because not many donors would actually end up coming and donating blood, and there were issues even in collection and processing of these blood products. We usually also talk to the advocacy groups, so different foundations such as thalassemia, sickle cell, the administration and leadership has to be involved. So they are very, very important to make these strategies helpful and successful. And, some of the things that we realized as we went along the line is we started looking at the outcomes. In one of the facilities and it's interesting that Australia is being mentioned, because Australia is really huge and vast, and there's a whole outback which there. So as I think Dr. Shrestha or Dr. Hina, I don't remember, were mentioning one doctor for 1,000 patients. It's even more for many of the thousands of patients, even in Australia. But the best part is when you look at the outcome, you realize the importance of how much, dollar value did you save? How many patients' life did you save? And that is what is important. I think last but not the least, in the Western world, many of the things are dependent of the health insurance, which we don't really see it in India, because the moment you order a blood, it gets put it on your health insurance. So you have to actually also have a good conversation with your stakeholder, who's maybe an insurance company, or your pricing in your hospital. That is important. And last but not the least, what we have seen, and there is an interesting session also during the ABB presentation, is we have started to speak to many of the social media, such as the serials that are coming up. Everybody likes to see television, whether it's a Hollywood movie or a K-drama or any of these things. What we have realized is there's an awareness being created. So all the stakeholders, including your advocacy group, including donations, are being, amplified. And then it gets transferred to the clinician as well, because the clinicians realize that, okay, my patients are now taking active role in whether it's donating, whether it's taking care of themselves, and, helping all of that. And that can be assessed by doing, we used to do a sort of a trophy or a leadership. So we had a lot of competitions inside the hospitals, inside the facilities, to say who did save the maximum dollar money, who utilize the blood, very nicely, and it gets translated because most of our surgeons, our doctors are highly competitive. So it ended up in a very successful program. So these are some of the strategies that we are involving. And as everybody mentioned, that, all of them are really key factors in, promoting PBM. So thank you so much, Rasika. I hope I answered your question. And if there's anything else, please get back to me. Thank you.
Very well.
Sorry.
Yeah, please.
Yeah, I also wanted to add something more to this. So, as you know, and you introduced me in my slide, that I'm an international ambassador for AABB, and it's such a wonderful collaboration of ATM and AABB. I encourage everybody to join, the Asia Pacific group, where we discuss some of these strategies for blood banking, cellular therapy, and all subjects, all topics which would interest you. I highly encourage it. And, thank you so much to Dr. Chaudhary and ABB leadership who's brought this along together. So thank you so much.
Thank you, Dr. Savri. That was actually very well covered. And yes, using the social media is a very good idea. So I think we can actually, put it as a part of the implementation process. And going on to next panelist, Dr. Poonam Malhotra Kapoor. Ma'am, PBM in itself is a very complex thing, and to decompose the complexity of PBM into concrete measures on each implementation level, I would need, the question to you is, what should be the matrix of measurement of implementation of PBM practices? Dr. Poonam?
Thank you so much for asking me to join you as a panelist. I think some people had I'm sure I'll make it up in my next call, and I'll send you the recording as you kindly give it to the speakers. And very recently in 2019 by the guidelines which have been shared across the globe. But yes, as Dr. Ajay rightly mentioned in his talk, it has not yet been implemented for 3 reasons and challenges and all. Every speaker has put forward their local concerns and global concerns. Is three pillars, and these 3 pillars have about 17 different drivers. One pillar is to improve the red cell mass and improve the preoperatively of patient. This is in cardiac surgery, see very, very important in the pre-op and peri-op period. A patient's borderline hemoglobin pre-op of 10 cell blood, and that especially in children and in women. This becomes a big challenge perioperatively, and post-op, this patient, if not optimized to above 10 or 12, would suffer in terms of oxygen delivery. The second pillar is the management of the perioperative bleeding concerns. Now, these perioperative bleeding concerns are again not managed well in most, maybe in tertiary hospitals, maybe in metros, yes. But since most people do not know the trigger points that even Dr. Ajay mentioned about, these trigger points, these driving forces of how to, which is the blood most used? Is it alone INR? Is it a PG? Do you need to do an APTT, let's say when you're on an ECMO or on a ventricular assist?
I think there's been a voice drop. Dr. Poonam, I think there's a voice drop, connectivity issue, I guess. Am I audible, Dr. Poonam?
Can you hear me?
Your voice is cracking, Dr. Poonam.
Okay, to better area. Can you hear me now?
Yeah, better, much better.
Yeah, better. So the third is very important, which most of us don't do. That is optimizing the blood loss, and that is taking care of the cardiac output, the oxygen delivery, the oxygen consumption. These are very important things if you want the patient back onto their feet in a good time and managing the bleeding. So even though, and that is by restricting the transfusion and giving the correct blood component therapy. That's important. I may need, if my fibrinogen levels is less on an ECMO or in a cardiac surgery because of hypothermia or cardiopulmonary bypass or hemodilution, I want to give this patient cryo. I don't want to give a packed red blood cell because my hemoglobin on this patient may be 11, but my 15 or my PF-SON on this patient is less because CPB and ECMO bring in the use of heparin, and heparin causes thrombocytopenia. So these measures are very important, that you have an optimum hematocrit and you have at the same time the right blood component therapy given with temperature care, oxygen delivery care, as well as cardiac output maintenance with IV fluids and inotropes, so that the patient's forward blood flow is maintained along with the blood infusions given, the right ones. So you need point of care tests, which are very important, which are not very well aware of. Most physicians are not aware of these tests. You don't need expensive machinery. You need just one machine, maybe sufficient. We use a sonocart, we have a rotum, and on this, maybe 20 cases a day that are done are more than sufficient. So cost effectiveness is important, so are the blood transfusions, but restrict the blood transfusions to bare minimum. That is the era we are in. Do not give massive blood transfusions. So that third pillar is very, very important. And when you have these 17 drivers, you can make a matrix of scores of them. And this is what the guidelines have said. Make the awareness, correct the trigger points, drive home the 17 drivers and put them into 3 pillars and have a score for each individual patient needing individualized treatment. And as rightly put by everyone, PBM in India needs to be pushed away from the metros into the second and the third tier cities as well, because that's where the bulk people is, and blood bank people we as researchers can do it. The surgeons need to implement it, and PBM as a course in medicine MBBS should be a subject so that everyone's aware of it. Thank you so much.
Thank you so much, Dr. Poonam, and I think that was very well covered. And now the trickiest one comes your way, Dr. Gandhi. Is there a recipe or a step-by-step approach to PBM implementation in an institute or a region? And what should be the approach for formulation of PBM guidelines?
Thanks, Dr. Rasika, for your question. I'll start with a saying. Probably I only quoted it. There is no fixed formula for success, but the mathematics remains the same. It's just a good combination of facts and figures, which can lead us to a so-called practically feasible approach. So I would say the beginning or the first step is to have a mandate. Now this mandate should be from top to bottom. It's not that you and me or people around us, they decide. It is the administrators, it is the policymakers, it is the health regulators who have to give a mandate that this has to be done. Because unless you have the dictum, unless you have the intent of people who would actually take it forward, sorry, all our efforts are going in vain. Once we have a mandate, now this mandate need not be for a country. This mandate could be for an institution. This mandate could be for a state, for a region, for a province, whatever structure we are responsible or accountable for. Now, second, having a mandate is probably the first step, I would say. Then, analysis is something which is most important, because I remember a few days back, we were discussing this in another meeting where we wanted to have a survey of what is the existing infrastructure, what are the resources, population matrices, which is very important. And most important, healthcare practices. We need to do a survey. Once we have the relevant available information, next point should be to do a gap analysis between what is existing and what is, say, the ideal or the most recommended one. Now, this gap is the one we have to work on. If you're sitting at, say, level 10, fine, you don't have much work to do. But if you're sitting at level 1, There's a long way to go to cover that step. Now, this gap between the ideal and between the existing is what is going to define what is a journey to be covered. Once we have those, we have the gap, we need to form subgroups. Now, why I'm saying subgroups is because not everybody will be well versed with the practices. So we need administrators to work on their own KPIs. We need the fraternities, the sub-fraternities like the surgery, the transfusion medicine, the ops and gynae, the trauma, transplant. They have to work on their respective, needs and requirements. Once we have the recommendations or we have the consensus available from these various sources, we need to put them together in the form of a strategy. Of course, we need to work on the call to action and evidence-based recommendations when we are looking at uniform, holistic, and most important, sustainable guidelines. Now, I will be discussing this in my next question, but biggest problem will not be just moving on a path or choosing on the path of patient blood management. The problem will happen when we have to sustain it. When this becomes a habit, to continue making it a habit will be a bigger challenge. Believe me, this is what's going to happen next. And let us all look forward to that next challenge we all are moving towards. Whatever recommendations we have, whatever protocols we have, make sure they are endorsed by the corresponding stakeholders. It's not just that today surgery fraternity decides to have, say, a trigger point of blood transfusion for say a hemoglobin or a PCV value. Make sure that they are accountable for it and they have evidence behind it to recommend that this should be the trigger point for starting or initiating transfusion for the so-and-so patient. Now, coming to formulation of guidelines, I would say I have just interacted with so there is Dr. Philip Augusto in Mexico, who is probably the driver of formulating the PBM guidelines in Mexico. He has done immense work. He started somewhere in July 2017 when he started working on the process, and last year they formed the Mexican guidelines on patient blood management. I had just had a very long discussion with him. He says, for me, the bigger challenge is now is we are not able to implement it universally. We have formed it, fine, but we are not able to implement it. How do we implement becomes a question. Most important, what Poonam Madam addressed beautifully is the matrices of measurement of implementation. Now, we all know that we need to run, and we are running, but we need to have a check how effectively we are running, how wonderfully we are running. So we should have our own checks and balances on deciding what are the matrices of user, implementation as such. Biggest, of course, Dr. Hina addressed it. What are the no-nos? What are the don'ts? But I would say one don't that I would like to recommend before the rest of the group here is never ever aspire to have pockets of recommendations or guidelines or protocols. Always have holistic, multidisciplinary. Europe is struggling. They have surgery guidelines, they have cardiac guidelines, they all have PBM guidelines. PBM guidelines from Surgery Association, PBM guideline from Pediatric Association, PBM guideline from Cardiac Association. They have at least 6 different set of guidelines. Ops and gynae is another one of them. Now, there is a disconnect between those guidelines and recommendations. It's a patient who's bleeding. He is not saying only a pediatrician can handle me because I am of that age group. Only an obstetrician can handle me because, say, I'm about to deliver a baby. I've just delivered a baby. It's the blood which is coming out or likely to come out. It has to be a cumulative call. It has to be a multidisciplinary call. Last statement, I would say, we have to evolve from just being transfusion committees to becoming PBM task force in our respective hospitals, institutions, regions, states, provinces, and country as such. we have to ditch the concept of just restricting to transfusion committee. That's it from my side.
Thank you, Dr. Gandhi. I think that was well summarized. And I think, we've created that enough buzz around, and now it's time to just embark on it. And I now would hand over to Dr. Amita. Dr. Amita, over to you.
Yes, ma'am. I think we are running short of time also. I invite Dr. Amit Shrestha to deliver the vote of thanks. Dr. Amit.
Thank you, Dr. Amita. Well, as Dr. Chaudhary had mentioned earlier, that AATM PBM group is a very newly formed group, and in fact it was formed only this January. And as a first step, we have AATM has been able to organize this webinar, and I see it as a very grand success. We had about almost 80 participants from different parts of the world. And I would like to thank our eminent key speakers, Dr. Poonam Malhotra Kapoor, for our excellent presentation on anticoagulation and ECMO. And I would also like to thank Dr. Gandhi for his elaborative and excellent presentation on the journey of patient blood management in India. And also, in fact, I would also like to thank him for coming to Nepal. Hope to see him in Nepal in future as well. And I would like to thank our all the people involved, especially IT people, for helping us to conduct the webinar smoothly. I would also like to thank our AATM PBM group, our chairperson, Dr. Sadhana, Dr. Jeda, Dr. Amita, for working very hard to make this program grand success. And last but not the least, I would like to thank Dr. Navjot Chaudhary sir for his constant hard work and effort to take AATM to a height, and introducing the PBM and coming up with the PBM thing, and bringing us all together. So thank you, everyone, and hope to see you soon. Thank you.
So this journey is not coming to an end. We will continue with this journey, and we will come up with new agendas for this PBM implementation. I hope we all move forward together in this journey, holding hands, and as the theme goes, joining the dots. So we all hold our hands together and we move forward in this journey of PBM implementation. Thank you, everyone.
Thank you, Dr. Rasika. Thank you, Dr. Amita and Dr. Sadhana, and all the esteemed members, Dr. Amit, Shrestha, Ajay, Dr. Chaudhary. Thank you for including us, and it's a wonderful first step forward. Look forward to many such more. Thank you.
Thank you, ma'am. So happy weekend to everyone.
Thank you, everyone. Thank you.
Thank you very much. Thanks.
Thank you. Goodbye.
Bye.